All right, party people, we are back at it with another one. Let's get it. So, if I was to give you a 30-year-old female pregnant at 30 weeks gestation, she's got a 5-day history of costophrenic angle pain. She has a temperature of 102 Fahrenheit, and this histoslide is associated with her findings. You might be saying, WTF is costophrenic angle pain? Let that marinate. Anyways, which of the following is most likely to be seen in this patient? Please make your selection. 3, 2, 1, boom. There it is. Let's get into why the correct is correct and the incorrects are incorrect. All right, jumping right into amniotic fluid embolism. This presents identically to a pulmonary embolism, except the key historical detail is that it occurs minutes after delivery of the placenta, usually within 30 seconds to 2 minutes. So for example, if they say 2 minutes after delivery of the placenta, a woman develops acute shortness of breath and tachycardia, now you're thinking amniotic fluid embolism. Also, it's associated with DIC, that's disseminated intravascular coagulation. This can result from amniotic fluid embolism. So you need to know that if you start seeing bleeding from IV or catheter sites or schistocytes on peripheral smear, you're thinking DIC. Another high yield cause you might have to associate is with acute promyelocytic leukemia. This is due to the release of our rods. Next up, we're going to get into chorioamnionitis. Now in this case, this has to do with inflammation of the endometrium. Now, a key distinction has to be made between endometritis and chorioamnionitis. You cannot be pregnant and have endometritis. So if you're pregnant plus uterine inflammation, that means you have chorioamnionitis. If not pregnant, now you will be thinking endometriosis or postpartum endometritis. In this case, what they would give you is a woman had a C-section a couple days ago, now is febrile with lower abdominal pain. Now you're thinking postpartum endometritis. Now you also have to know that for postpartum endometritis, this is a major risk factor for pelvic septic thrombophlebitis. This is due to infected clots from the endometrial venous drainage. Treatment usually is ampicillin plus gentamicin plus minus clindamycin. Now moving on to our correct answer, which would be the obstruction of the ureters. Now in this case, this patient has pyelonephritis. Now pregnancy is a major risk factor for pyelonephritis for 2 reasons. The first being ureteral compression, which is what we have here. This is usually in the 3rd trimester. However, there's also a second component which must be factored in, which is progesterone. This slows the ureteral peristalsis. So progesterone also slows biliary peristalsis, which results in bile sludging, which can then increase the risk of gallstones. Also, estrogen increases HMG-CoA reductase activity, which boosts cholesterol synthesis, which again can increase gallstone risk. So an asymptomatic bacteriuria is treated during pregnancy, even though we don't treat it in non-pregnant patients. This is because of the increased risk of pyelonephritis from urinary stasis. Now, getting to the histoslide. I know you're not a histopathologist. USMLE knows you're not a histopathologist, but we have to at least cover the basic. That being, the pink areas that you see here are eosinophilic. The purple/blue areas are basophilic. And what you see in those purple-blue areas is neutrophilic infiltration. So this is essentially an image of acute inflammation. For example, like in this case with pyelo. Doesn't matter which tissue they're showing you via histoslide, if there is neutrophilic infiltration, they'll more or less look like this one. And quite honestly, you wouldn't be able to tell the difference anyways. So we just have to go over the basics. So the key takeaway is lots of basophilic cells equals acute inflammation. Think neutrophils. Now getting to the costovertebral/costophrenic angle tenderness. Now costovertebral angle tenderness is pathognomonic for pyelonephritis, but in this case they chose to use costophrenic. That's fine. You don't have to worry about it. It's basically the same thing. So costophrenic angle tenderness usually refers to chest x-rays and pleural effusion. However, in this one, they wanted to refer to pyelonephritis. Just accept it. No need to argue with USMLE about it. Moving on. As far as prolonged rupture of membranes is a risk factor for chorioamnionitis, which is inflammation of the fetal membranes during pregnancy. If the mother's group B strep status is unknown, you will give intrapartum IV ampicillin or penicillin. If rupture of membranes lasts longer than 18 hours, maternal fever is over 38 Celsius, or it's a preterm delivery, meaning less than 37 weeks gestation. Moving on to inflammation of the fallopian tube, also known as salpingitis. Here, inflammation of the fallopian tubes typically is due to pelvic inflammatory disease. This is often caused by Neisseria gonorrhea or chlamydia. The classic buzzword for this finding is cervical motion tenderness. Treatment includes ceftriaxone for gonorrhea or doxycycline or azithromycin for chlamydia. Now, ceftriaxone is normally administered intramuscularly. However, if the patient is septic or is an inpatient, IV treatment may be required. So just as a wrap up, for key points, here the diagnosis was pyelonephritis. The histo slide shown was neutrophilic infiltration from acute inflammation. The mechanism by which the problem occurred was due to obstruction of the ureters, as well as progesterone-induced stasis. Now, costovertebral angle tenderness or costophrenic angle tenderness are interchangeable. This is typically found during pregnancy. You will have fever as well as back pain. All right, that's it for this one. Go crush it.